And we're back for the third and final presentation of today, day one of the virtual PKD Summit. I'm very excited to introduce this next speaker. Thomas Weimbs is a professor at the University of California in Santa Barbara, where he directs a research laboratory focused on polycystic kidney disease. He received his doctoral degree from the University of Cologne, Germany, and then conducted postdoctoral research at the University of California in San Francisco. In 1999, he started his first independent research laboratory at the Lerner Research Institute of the Cleveland Clinic as an assistant professor. There, he started to research PKD after he was approached by a local family affected by PKD who financially supported PKD research in his newly founded lab. Their family foundation still supports PKD research in Dr. Weimbs' lab today. In 2005, Dr. Weimbs moved his laboratory back to California to join the Department of Molecular, Cellular, and Developmental Biology at UCSB. His laboratory studies molecular mechanisms underlying PKD with an emphasis towards developing new therapies. Research from Dr. Weimbs' lab has led to a better understanding of PKD and led to novel methods to deliver therapeutics specifically to polycystic kidneys. Some of the most recent research has led to the discovery that dietary interventions and commonly available and safe dietary supplements can prevent cyst growth in animal models of polycystic kidney disease. Research in Dr. Weimbs' lab has been funded by grants from federal agencies, including the National Institutes of Health and the Department of Defense, by private foundations, including the Lillian Goldman Charitable Trust, the Amy P. Goldman Foundation, and the Jarrett Family Fund, as well as several biotech companies. Without any further ado, it's my great pleasure to welcome Dr. Weimbs to the presentation today.
All right. Hello, everyone. Thank you for coming. It's a great pleasure to be here. My name is Thomas Weimbs. I'm a professor at the University of California, Santa Barbara. And you can see the campus right here. I'd like to tell you today about our latest research on diets and dietary interventions in polycystic kidney disease. But first, my disclosures. So besides my day job at UC Santa Barbara, I'm also the founder and president of Santa Barbara Nutrients. And you can see some other things here, but the most relevant one is the first one. Good. So, just a disclaimer ahead of time, always consult your doctor before changing your diet or taking any supplements or medication. So this is not medical advice, anything I'm saying here. So keep that in mind. All right, here's the team in the lab at UC Santa Barbara. Today I'll be presenting mostly work from Jacob Torres and from Sebastian Strubel in my lab. And they're supported, by a large team of other folks as well. All right. So I think everybody is very aware of what autosomal dominant polycystic kidney disease is, or ADPKD, and what the sort of the general recommendations are usually to patients with regard to diets, and that is typically drink more water, limit sodium. And of course, once a patient progresses to renal failure, the treatment is either dialysis or kidney transplantation after renal failure. There's only one FDA or EMA approved drug out there, that is tolvaptan. This drug is not available to all patients, only a fraction of them. It only slows the progression of the disease, so it does not actually stop the progression or even let alone reverse it. And of course, as most drugs, also tolvaptan has some very significant side effects and toxicities. And another drawback, of course, is that it's a very, very expensive drug, costs about $150,000 US per year list price to treat a patient with it. So clearly, there's room for improvement. We all want to find something better that patients can take to improve their disease and their health. So today I will tell you about some research coming out of my lab and sort of related research coming from many other labs. And I've broken it down into 4 different stories. So the diet story 1 is about ketosis, excuse me. The diet story 2 about keto and in human ADPKD. And story 3 is about crystals. So what could this be? You'll find out very soon. And the 4th one is where I put it all together and tell you about sort of a dietary management protocol that in collaboration with dietitians we have developed, as well as clinical trials that are going on or starting or are planned. All right, let's start with the first story, ketosis. This story is largely based on a paper we published recently in Cell Metabolism, first authored by Jacob Torres from my lab. And this paper made a relatively big splash in the field and got a lot of attention. So let's go through it. But before we go through it, let me just give you a very brief background what this is all about. So research in recent years, fairly recently, has sort of revealed that PKD could be considered a metabolic disease. So there are actually metabolic defects on the cellular level that affect the cyst cells in the affected kidneys. And these cysts have defective mitochondria. Those are, the energy producing organelles in the cell. The cysts have a defective fatty acid metabolism, so they cannot burn fatty acids very well for energy. They instead depend on glucose, some blood sugar essentially. And this is very similar to the what's called the Warburg effect. That is a sort of a metabolic change that has been observed in many forms of cancer as well. So this is sort of the bottom line coming out of research from many different labs. And, I'm just put a few papers here to illustrate this. So clearly there's something metabolically wrong in these cyst cells in PKD. And the way we kind of like first you stumbled on it with regard to dietary interventions was when a student in my lab, and that was way back then, wanted to inhibit what's called the mTOR pathway. It doesn't really matter what it is, but many years earlier we had already found that the mTOR pathway is activated in cysts and PKD and seems to drive cyst progression. So the student in the lab wanted to inhibit mTOR by feeding mice with PKD less food. He didn't tell me and didn't ask me about it. He just did it. And I would have never thought that this would work. So I would have told him to not do it. But luckily I was not informed, if you will. And all of a sudden the results come up and the results were really stunning. So what he did is he put the mice on a reduced food intake regimen with a 23% reduction in food. So a very mild reduction. So the food was the same. He didn't change what kind of food it is, only the amount of food, and only very mildly. So, and lo and behold, what happens is, there was really no effect on body weight or anything like this. The animals were not malnourished. However, the kidneys were much smaller. So you can see here is on the left is a normal kidney from a normal mouse. In the middle is a polycystic kidney, from one of these genetically engineered PKD mice. And then on the right is the polycystic kidney mouse that was on the reduced food reduction in regimen. So we did, a lot of work trying to characterize this, but essentially scratched our head and said, okay, there's a great effect. We don't know how to explain it. We published a paper like that. And in the same year, almost exactly at the same time, actually, a very similar paper came out from the Mayo Clinic showing almost, very, very similar results, excuse me, where they put mice on either a 40% food reduction or even a 10% food reduction and had very similar results, a dramatic effect on cyst growth in their kidneys. Nothing else bad happens. So, and same, for them, they also couldn't really explain the mechanism why this worked. All right. So since then, we've been trying to figure out why this works, what are the mechanisms. And to explain this a little bit better, I have to kind of like do a little Physiology 101 recap. And you might be able to tell that I'm a university professor, so I'm giving lectures for a living. So there is a metabolic state of ketosis. It's called ketosis, and that is actually a normal physiological state in us humans and all other mammals. To explain ketosis, we have to first explain what happens if we're not in ketosis. So if we're not in ketosis, that usually means, we're eating ad libitum, whenever we want. We eat high carb diets, which is, what most Americans consuming, very high carbohydrate foods, which means that we always have fairly high blood glucose levels, blood sugar levels, and everything else that comes with it, high insulin and so on. And this essentially means that our body fat takes up a lot of the glucose and converts it to fat. And the fat tissue, the adipose tissue keeps growing and growing. And it's how we become overweight and obese. And the glucose also feeds all the organs and tissues and cells in the body, for example, the kidneys down here. And that's just how it goes if you're on a high carb diet. If instead you stop eating and now are fasting, our body can switch over. So when we're fasting, we're not consuming carbohydrates, our blood glucose levels go down. They never go down to zero, of course. Our insulin goes down, and that signals to the fat cells that they now have to release these fats in the form of fatty acids. And that's really the only way how we can lose weight, we as people, by being in ketosis, in the state where we have, lower glucose levels and our body fat lets go of the fatty acids. So these fatty acids can then supply the organs and tissues and cells with energy instead of glucose. And what also happens is that some of the fatty acids are taken up by the liver and converted to another compound or a set of compounds called ketones. And that's actually where the name ketosis comes from. And these ketones are also energy molecules. They get taken up by these organs and cells and burned for energy. So when we're fasting, our body really switches over away from using glucose and towards using fatty acids and ketones instead. And these fatty acids and ketones ultimately come from our fat tissue, which means when we're fasting, that's the chance we have to shrink our fat tissue and lose weight. All right, so the main ketone that is produced by the liver is called beta-hydroxybutyrate, complicated word, BHB for short. We always call it BHB. So maybe keep a pin in this. I'll get back to BHB very shortly. So this is what happens during fasting. We get into ketosis, and then we can go back, once we eat high carb foods again, we go back into a regular mode. And in evolution, you can easily argue that a prehistoric human or even a pre-human, if you will, would have been in and out of ketosis all the time, right? So they wouldn't have had a refrigerator, a food pantry. There were no grocery stores at every corner, no bakeries. There was no freezer, no way of preserving foods, really. There's no agriculture. You don't have grains and anything like this. So those folks were hunter-gatherers, and they ate every once in a while, maybe one meal a day, maybe one meal every couple of days. And then, of course, there's the winter time where maybe they didn't have any food for a month, and they would have been in ketosis in and out very, very frequently. Today, nowadays, in our lifestyle, we are most people in Western societies are almost never in ketosis because we start eating breakfast, we finish with a late night snack, we have lunch, we have dinner, we have snacks in between. So we're never getting to the stage where our fat tissue actually lets go of the fat, and that's how people become obese, and that's why we have a obesity epidemic. So anyway, so here's what ketosis is. All right, so how do we now explain why reducing food intake is so effective in mice with PKD? So what it came down to is the observation that mice that are at libidum fat behave just like Jerry the mouse living in a cage of cheese. They eat all day long, they nibble a little bit here and there. And that's how they live. That's what mice do when they have a mountain of food right next to them. However, the mice that were on a reduced food intake protocol, they were only fed once a day with a pre-weighed amount of food. And what I imagine happens, in the brains of these mice is, they're thinking, oh, there's food coming only once a day. I better eat it all before somebody chases me away and I miss my chance. So they learn very quickly to eat their food all in one sitting in 1 hour. So they eat breakfast, lunch, and dinner all in one go. And then they're done eating in an hour. And, they're, probably getting a little bit obese intermittently. But then they're fasting for the remaining 23 hours. So they actually don't get any food because they've already consumed it all. So what that means is that the reduced food intake protocol is actually an intermittent fasting protocol. All right. So now you can see where I'm going with this. This is actually not caloric restriction. This is actually fasting, the induction of ketosis. That's what we found. All right. So so we tested all this in different animal models of PKD. We have a rat model, a mouse model, a cat model. And we subjected them to different types of dietary interventions, such as time-restricted feeding, ketogenic diet. I will explain in a second what that all is. Acute fasting, BHB treatment, and a couple of these models, the mouse and the cat model, are what's called orthologous models, which means that in them, the same gene is affected that's also affected in humans with PKD. The PKD1 gene. All right, so we studied these animals, and I'm just going to show a couple of experiments to illustrate. So here, for example, where we treated the rat model by time-restricted feeding. The ad libidum control animals are shown up here. So here's a 24-hour cycle, from all day long, essentially. The ad libidum animals have access to food whenever they want. The time-restricted animals only have access to food for 8 hours. So that's this part here. And the food is the same. There's no difference in what they eat, only a difference when they eat. They end up eating the same amount of calories. So there's actually not even food reduction going on. But see what happens. This shows what's called the 2 kidney weight as a % of total body weight ratio. So we're weighing the kidneys, we're weighing the body, divides this to normalize it. And you can see that the cystic animals have these very large kidneys here. And in the animals that were on the reduced, on the time-restricted feeding protocol, all of a sudden, they're much, much smaller. And we can quantify many other parameters like cystic area, for example. So we can see they have fewer cysts and then smaller cysts and so on. And everything else we've looked at was dramatically improved. So this was interesting. No change in what they're eating, no change in how much they're eating. The only change is when they're eating. All right. And you can actually, in mice, for example, kind of measure what they're burning. So you can put mice in what's called a calorimeter and measure what's called the respiratory exchange ratio. It doesn't matter what it is. It just matters that, if the value is up here, that means the mice are burning carbs. If the value is down here, that means they're burning fat. And if you give them, food once a day, you can see they start carb burning mode very, very quickly. But then they run out and they crash down, if you will, into ketosis, and they start burning fat for the remaining half of the 24-hour cycle. Then you feed them again, they go up into burning carbs, they crash back down, and you can do this forever and ever. And an alternative is to feed them what's called a ketogenic diet. So that is a very low carbohydrate diet and a very high fat diet. And that's done down here in the orange line here. You can see if you feed mice a ketogenic diet, they will be stuck permanently in ketosis and they're only burning fat. All right, so what is a ketogenic diet? It's actually a diet that has been used for about 100 years to treat epilepsy in children. It's also widely used these days for many other reasons. And in contrast to a standard American diet, the SAD diet, which is a very high carb diet, the majority of the calories come from carbs, the rest from fat and from protein. A ketogenic diet is kind of flipped around. So the majority of the calories come from fat, very little from carbs, and protein stays the same. So we don't change the protein very much. And if you do this, the metabolism has no choice but to just burn fat, and then because there are very few carbs. So we did this in the rat model again with PKD, comparing animals on a normal chow compared to a ketogenic diet. And you can see what happens, is again very dramatic. The animals on a normal high carb chow have big kidneys. Those on a ketogenic diet have small kidneys. Cystic burden goes down dramatically. Everything else we've looked at dramatically improves. So here we're not changing when they're eating because everything is ad libitum. We're not changing how many calories they're taking because they happen to eat pretty much exactly the same amount of calories. The only thing we're changing is the metabolism that we want them to be in. And in ketosis, they're doing much better. All right, another experiment shown here is when we then found, okay, what if it's just a ketone BHB that can maybe mimic the beneficial effects? So you can actually feed the BHB, we put it into the drinking water for these rats and see what happens. And to my amazement, I would not have thought that this would work, but strangely it actually did. These are, big kidneys of cystic kidneys of just, regular fat rats. These are normal rat kidneys, they look much smaller. And these are the cystic kidneys, the polycystic kidneys of rats that were supplemented with BHB in the drinking water. And they looked almost the same as the normal control kidneys. So, and you can see the effect here, again, 2 kidney weight as a % of total body weight ratio, control diet and control diet plus BHB, very dramatic effect. All right, so this all looked really, really interesting. And, there were, lots of additional studies in this paper, of course, including a human study here that we did where we analyzed people with PKD that are non-diabetics, and they don't have diabetes, they are normoglycemic, they have, kind of glucose levels in the normal range. And we tested whether the baseline serum glucose levels might correlate with the progression, the average change in total kidney volume. So the faster somebody progresses, the more the kidney volume changes. And the bottom line here is that there was a correlation. The more glucose people have, the faster their kidneys tend to progress, or the kidney disease tends to progress. And this actually correlates well with known, tidbits and known data in the literature. Hyperglycemia, so high glucose levels, and type 2 diabetes have already been known to correlate with faster PKD progression. Also, obesity and overweight correlate with faster PKD progression, and those usually mean somebody is on a high carb diet that tend to have higher glucose and insulin levels. All right, so that's all very interesting. The take-home message here is that dietary ketosis appears to inhibit PKD progression, and that that BHB supplementation appears to be able to kind of mimic these beneficial effects. Of course, what does this mean for clinical translation? Dietary ketosis is something that is just a change in diet. Essentially, it's not even a drug. Supplementation with BHB is also not a drug. BHB is freely available as a dietary supplement. It's what's called generally recognized as safe. So it's essentially a food ingredient. So that's all very interesting. What about keto, or ketosis in humans with PKD? What can we find out? What can we test? Just to recap, of course, during human evolution and, depending on where you start counting, this might be 5 million years or 2 million years. So depending on where you start, our bodies have evolved and our genes have evolved to become a really well-oiled machine with the lifestyle habits and the dietary habits that we had during these 5 million years. And then something strangely changed in the last maybe 50 years or so, where we suddenly have dietary guidelines for Americans recommending high carbohydrate diets. And all of a sudden, within just a short span of 50 years, many of us look like this instead of this guy. So something strange is going on, right? You'd think, could it have to do with high carb diets and maybe the fact that we're never in ketosis anymore? That's certainly a possibility. So what we wanted to do is see if we can find a cohort, a population of patients with PKD that have already experimented with low-carb ketogenic diets. And we did, so we recruited patients into a retrospective case series study, identified 131 or enrolled 131 patients. Most of them did a classical high-fat, low-carb ketogenic diet. Some did time-restricted diet, and some did also a combination of both. But all of these are sort of like ketogenic diets in the sense that one gets into ketosis at least every once in a while. So very interestingly, and what would be expected, of course, is a change in body weight. People tend to lose weight, and you can see, before versus after, there was a statistically significant difference in body weight. Many people in the obese and overweight classification came down to normal weight. Nobody became underweight. And this study was actually done by Sebastian Strubel in my lab, a nephrologist in my lab. All right, so we asked these patients in a very long questionnaire using a phone-based interview, many questions, including about their health and well-being. So one question here is, what impact did your diet have on your health or well-being? Very interestingly, the vast majority responded that that their diet strongly improved, or at least somewhat improved, their health and well-being. So that was very interesting. I should back up here. I forgot to mention one thing. The average duration in this population here was about 6 months on the diet. So half a year was the average. All right. So what were the health issues that they had before starting the diet, and how did they improve or worsen after the diet? And you can see it's a typical health issues that plague many people with PKD, flank and back pain, fatigue, abdominal fullness, acid reflux, and so on. And you can see that very frequently these health issues actually improved with the diet. So that was very interesting. What about actual data? So blood pressure. Let's start with blood pressure. So self-reported blood pressure. People tend to measure blood pressure before the diet and after the diet. And surprisingly, or maybe not surprisingly, because it's already well documented that ketogenic diets actually have a strong beneficial effect on blood pressure. And as you can see, that was the case here. So this was actually statistically significant. Almost every patient, and you can kind of trace them back here, almost everybody improved their hypertension. So that was very interesting. Another result, we looked at kidney function measured by eGFR, the creatinine levels essentially. Surprisingly, there was even a statistically significant increase in GFR, if you compare before and after the diet. And the increase was even a little stronger if you narrow this down to patients that had documented ketosis, meaning they had actually measured their blood ketone levels and could document that the ketosis was increased. So there's a caveat, of course, if the glomerular filtration rate or the eGFR, improves, that doesn't mean obviously that there are new nephrons growing or anything like this. So, and many nephrologists start screaming at me when I show them this, and they think this is not possible, that this cannot be. The kidneys don't regrow new nephrons. Of course they don't, right? So everybody knows that. So there are probably other explanations, and one explanation might be that potentially a reduction in cyst pressure may relieve pressure on normal renal tissue and allow the normal nephrons to function better. That's speculation at this point that remains to be determined. All right, feasibility. We asked them, how would you rate the overall feasibility of your dietary approach in daily life? Surprisingly, about 92% said that it was either no problem at all or no real problem, and they only skipped several times a month. So that was surprising, and probably points also to to be a bias in the sort of self-selection of the patients, that these were very highly motivated patients that really wanted to do this, the diet and were able to stick with it and didn't think it was a big problem. And would you recommend your diet to a friend or family with PKD? Majority said they either strongly or somewhat agree. All right, so that's a study. It just actually got accepted for a publication, so I'm expecting this to be published very soon. All right, so you can all read the details. All right, so what about other clinical trials? There's a very short-term clinical trial on sort of acute fasting in PKD conducted by Roman Müller. It's the University of Cologne. This trial is actually already finished, put together for publication, so I won't preempt anything here. It's a very small trial, so that, it won't be the end-all, be-all yet. But there's a larger trial that we have actually been planning together. So Roman Müller in Cologne is really running this study. So my input is, essentially just as a consultant. This is a study. I can show you some more details here. Essentially recruiting patients and randomizing them. It's a total of 63 patients that will be recruited. Recruitment is going on right now. The study is actually going on. They will be randomized into 3 groups: a ketogenic diet, intermittent fasting versus control, so no change in diet. It's for 3 months duration. And the endpoints are really primarily feasibility. What is more feasible to do? Is it a ketogenic diet? Is it intermittent fasting? How do patients adhere? Do they get into ketosis? Could there be kind of initial signs of efficacy potentially? So these data are going to come out probably early next year. All right, and I'm looking very much forward to it. I was just in Cologne actually a couple of weeks ago, and we looked, we talked about the study, so it's going forward very, very well. Other clinical trials, there's a trial at the University of Colorado in Denver that has just been completed. It's not published yet, but the group has released some of their data or discussed some of the data at a recent PKD conference. This was a 1-year study with 28 PKD patients that were overweight or obese, and they were put on a daily caloric restriction or intermittent fasting regimen. And interestingly, those patients that actually lost weight showed the lowest increase in total kidney volume. So they had the least progression of their kidney disease. So, of course, if you, as I mentioned before, if you lose weight, that means you have to have been in ketosis at least, some of the time. So that is, of course, very interesting, and I'm really looking forward to seeing, the details of the study. There's also a longer follow-up study that is going to start soon. All right, so switching gears real quick, I'm going to go back to the ketosis in just a second, but just sort of interjecting another story, which is the Crystal story. This also came out of my lab in a recent study in the Journal of Clinical Investigation, again, first authored by Jacob Torres. And just to show you the bottom line, what happens, in normal kidneys, kidneys are made up of these mini tubules, the small tubules, where the primary urine filtrate passes through. And every once in a while, our kidneys have a problem. And the problem is because the kidneys concentrate the urine, from a large volume to a small volume. And some of the compounds that the kidney wants to excrete, when you concentrate it too much, it tends to fall out of solution and precipitate and form microcrystals. And they can get stuck in these tubules, and they block the tubules, they injure these cells in the tubules and cause trouble. And in humans, these microcrystals can eventually go on to form kidney stones. And in humans, the most common compounds that form kidney stones are calcium oxalate, calcium phosphate, and uric acid. All right, what we discovered is that these microcrystals, when they get stuck in these tubules, they actually activate signaling pathways that are the same signaling pathways that are also activated in polycystic kidney disease. And this apparently has the purpose of dilating the tubule diameter so that these crystals can get flushed out. And in a normal kidney, once the kidneys are flushed out, everything goes back to normal after about a week. These signaling pathways are turned off, kidney diameters go back to normal, and everything is fine. So that appears to be the normal mechanism how our kidneys deal with microcrystals. In PKD, however, we found that these microcrystals initially, cause the tubule dilation, and then the tubules keep on going. They just grow and grow larger and larger. They never seem to be able to go back to the original volume here, and they form cysts instead. So you can actually make PKD progression worse. And this is just how these crystals can look like under the microscope. And just to show a couple of experiments, on the left here, we used a rat model of PKD, subjected them to high oxalate, and you can see this is again the 2 kidney weight as a % of total body weight ratio. If we don't give them oxalate, that's how big the kidneys are. If we give them oxalate, it makes the disease worse. We can do the same in this case, another rat model by adding more phosphate to the diet. It's just essentially only a doubling of the phosphorus content, which already had a very dramatic effect and made the progression much, much worse, and also caused these microcrystals. So we know how to make it worse, by giving animals oxalate or phosphate. And where does this come from? Where does oxalate come from? Oxalate comes from our diet, a lot of it, such as spinach, for example. Many plants actually use oxalate as a poison because they don't want to be eaten. Spinach is one of these poisonous plants, if you will. Phosphate, especially the inorganic phosphate, is a very common food additive in processed foods, processed meats, in sodas, and so on. So we know how to make it worse. How can we make it better? We can make it better by supplementing animals with citrate. So essentially citric acid. So citrate is actually a normal compound that our cells make and our body makes, and the kidney uses it as a defense to prevent these crystals from forming, because citrate binds to calcium and just prevents these crystals from forming. And if we treat animals with citrate, just again the drinking water, you can see it has a very beneficial effect, and we can quantify this again. This shows sort of a titration curve, different amounts of citrate, makes the progression of the disease much less severe. Cyst size goes down, and amazingly, this was already known for 20 years. Blows my mind. So 20 years ago, a group of investigators around George Tanner in Indiana had published a series of terrific papers, meticulous science, very well done. They showed already that citrate supplementation in the drinking water preserves kidney function in a rat model of PKD, and it even extends their lifespan by, it almost doubles the lifespan. So these data were, stunning, and were published, and then soon forgotten. And the reason I think why they were forgotten is number one, they couldn't figure out the mechanism. Why was citrate actually effective here? They didn't make that link to crystals. And another reason why it was forgotten is because citrate is cheap. You can buy citric acid anywhere for very little money. So a pharmaceutical company would never be interested in developing this into a drug, for example, would not be sponsoring a clinical trial. And this has been almost completely forgotten until, we came up with this crystal mechanism, and that explains why citrate is effective. All right, so in our paper, we also had some human data, again, for ADPKD patients, and this shows a correlation of the urinary citrate level, so how much citrate is in the urine of these patients compared to the total kidney volume change. And essentially, it's an inverse relationship. So the less citrate somebody has in their urine, the worse is the progression of the kidney disease. And this is very well supported by other clinical literature. PKD patients actually have abnormally low urine pH, abnormally low urine citrate. They frequently have kidney stones, and those patients with kidney stones have typically faster progression of the disease. There's also a link between high uric acid levels and even gout and faster progression of PKD. And uric acid is another one of these compounds that can form crystals in kidneys. So, all right, let's put this all together in the Diet Story 4 and talk about combining what we have learned about keto with what we've just learned about citrate and see what we can do. All right, so we've actually combined BHB and citrate, putting it together in the drinking water, treating rats with this combination at different doses and different combinations, and find that they're kind of synergize with each other, allowing us to reduce the dose of both BHB and citrate that we need to administer to get the full efficacy here. And this actually led to, and this is not advertisement or anything, just like informational, this led us to, found a company, to launch a company out of UCSB. It's called Santa Barbara Nutrients. It's what's called a benefit corporation, launched about a year and a half ago, with the goal to make kidney-safe compounds available. In this case, as what's called a medical food containing BHB and citrate, because both of these are already approved food ingredients. And this will be a formulation recommended for people with PKD, with mild to moderate polycystic kidney disease. It delivers exogenous BHB to support this pathway. It delivers citrate, also what's called an alkali load, so it helps to normalize the urine pH and the urine citrate, and overall kind of bring people back to where they would normally be if they didn't have polycystic kidney disease. There's also calcium and magnesium in there, and this medical food is to be taken with a meal, and the calcium and magnesium will help to absorb or to suppress the absorption of oxalate and phosphates, so as to have a bit of an added bonus there, if you will. Anyway, so I'm very excited also about a terrific collaboration with renal dietitians. They're really awesome. Jess Saville, Diana Bruin, also Meg Munitz, and there's a whole other team behind them from a nonprofit company called Renaline. We've been working them for about almost 2 years or so to come up with a dietary program that takes all these scientific findings into account and puts it all together. So that's what they do. They're clinicians. They treat people with CKD all the time for a living, and have come up with this plant-focused, sort of crystal-managed, clean ketogenic diet for ADPKD. And we call it the Renew diet for renal nutrition, or you renew your kidneys. So the Renew a nutrition program for PKD. The features are it's a ketogenic diet, and it's not, it doesn't have to be a strict ketogenic diet. There are many different varieties of it. But this will help decreasing blood glucose, raising BHB, reducing fat body fat and obesity if that's present. But of course, this is also meant for people that are not obese. It's plant-focused, which leads to sort of normalizing urine pH, lowering uric acid. It's low in oxalate to avoid, obviously, the stressor oxalate, and the same for phosphate. And also integrates this medical foods that I mentioned, called Ketocitra, that delivers BHB and citrate. So this dietary approach is essentially an online training program, a 12-week program. There's first an initial onboarding phase where everything, patients get screened and their blood panels get screened, and there's pretty tight clinical supervision here. And then the program starts. It's all online and kind of scalable, if you will. In the first 6 weeks, if you will, it's more of a boot camp style regimen to get people into ketosis and to get them keto adapted or fat adapted, so that the bodies actually learn how to do this, how to burn fat and how to use fat and how to use ketones again and what to do with them. The next 6 weeks are sort of the fat adapted state that is meant to, where the dietary changes are meant to become sustainable, and it's very individualized. Everybody can kind of figure out their own pattern that works best for them. There's a lot of nutrient tracking involved. There is management of oxalate, phosphate, electrolytes, fluid intake, and so on. The patients learn how to monitor their own health parameters. They measure blood ketones, blood glucose, urine pH, blood pressure, and so on. And the goal is to use this program also, in addition to just offering it, we would also want to use this as the training phase for a clinical trial. So the patients that went through this and then at the end of it know what to do can be followed for a year afterwards, and the outcomes can be quantified and measured. So yes, so we're working on this, and I believe, that's almost it. We've just beta tested this whole program with a group of about 25 people with PKD. It went really, really well. We got a lot of feedback, and these are just some testimonials that the patients gave us. I'm not going to read them. You can, if this is being recorded, maybe you can go back and read it later on YouTube. All right, that's it. Just to point everyone to, sources for information. Everyone who's on Facebook, for example, is welcome to join my lab's Facebook group. There's also a Facebook group of the Renew program, which is really terrific. There's a lot you can learn there. Yeah, that's it. Thank you very much for your attention. And if anyone has any questions, I'd be happy to answer them. Thank you.
Thank you very much, Dr. Weimbs. That was a fantastic presentation. A lot of great information there. And of course, we know the activity on your Facebook page is very educational and resourceful. And I'm a member of both those groups. So I see the dialogue that ensues, and it's very exciting. This is a topic in the PKD community that has a lot of people buzzing. So I'm looking forward to getting through the questions with you. You can hear me okay, Dr. Weimbs?
Yes, absolutely.
Wonderful. Okay, let's get through this then. The very first question: I've tried intermittent fasting before and found that my mental alertness significantly improved. What would be the explanation for that? And if this is scientifically plausible at this time, is this being studied in CKD patients, giving the effects of uremia on cognitive function?
It's absolutely very plausible, and that has actually been shown many times that ketogenic diets, intermittent fasting, actually often improve mental alertness, and that has to do with the ability of the brain to utilize this ketone beta-hydroxybutyrate and BHB. It's actually the preferred energy source for the brain. If the brain has a choice to use either blood sugar or BHB, it much prefers BHB. There's a lot of studies that have recently come out, and it's a little bit of really like top notch science right now. That's at the cutting edge, where ketogenic diets and elevating BHB are being tested for improving cognitive functions in dementia, Alzheimer's, Parkinson's as well. So there's a lot of really interesting data coming out, and a lot of people that just do this, that do ketogenic diets. Almost everybody reports that they feel like they have more energy, mental clarity, and so on.
Excellent. Thank you. Thank you for that clarification. The next question, do you see a problem in ketogenic diets when you no longer have a gallbladder?
There is a problem. And of course, everybody should always talk to the doctor. The problem if one does not have a gallbladder is the solubilization of fats that one takes in with the, with the diet, and the digestion of these fats is impaired. There are ways around it. One can actually supplement the bile acids. So there are supplements one can buy, the doctor will definitely be able to advise, or a dietitian. Almost, this is probably a great case for to work with a dietitian, because that's right up their alley. That's what they do all day long, advising people with problems like this.
Understood. Thank you. In patients with ADPKD, is cyst reduction by ketosis also noted to reduce liver cysts?
There's unfortunately nothing known about this currently. So the studies we have done were all done in animal models in which liver cysts are not very common. So we could not study that in those models. That's something that is coming up that we're very interested in finding out. So for the moment, I can only say stay tuned, and hopefully we'll have some data, and maybe others will have data as well.
Understood. Thank you. I had a kidney transplant in 2014. I am on meds for high blood pressure. I have had a number of flare-ups with diverticulitis. I am not overweight. What diet would you recommend for me?
So again, I can't give medical advice, and that's a question where a doctor should be asked as well, and a dietitian. And I actually, by the way, I think a triangle of a patient working with their nephrologist and a dietitian is really the perfect scenario. And even if health insurance may not pick up the dietitian necessarily, I think it's well worth paying out of pocket if one can find a really, really good dietitian. So for someone who is post-transplant, I would say some dietary changes can make also a very big difference. And in particular, ketogenic diets are pretty well documented and well known to have a beneficial effect on blood pressure, so hypertension. So even in people that are not obese. So it's not, the beneficial effects are not really limited only to reducing obesity. This is probably one mechanism of that helps with pain reduction, but it's by far not the only mechanism. So ketosis triggers many mechanisms in the body, such as it increases what's called autophagy, where the body gets rid of essentially junk that has accumulated over the years. Ketosis is beneficial as an anti-inflammatory. It has anti-inflammatory effects, and that is all independent of whether somebody is obese or not.
Thank you. For a patient who wants to follow a PKD diet, what are the best fats and proteins to eat? What's the optimal source of fat-based calories to replace the carb-based calories?
Okay, great question to ask a dietitian who knows all this, but I can just say a few things about what we're doing in the Renew program, or what the dietitians are doing in the Renew program. One would want to be careful with one form of polyunsaturated fatty acids that tend to be pro-inflammatory, and that's those that they're called omega-6 polyunsaturated fatty acids. Unfortunately, that's the most common type of fatty acids that is in what's called vegetable oils, and vegetable oils are actually not from vegetables, they're actually from seeds, and that's something like canola oil, soybean oil, and so on, which have become so ubiquitous that the dietary intake in those fats has, in the last 50 years has gone through the roof, and those are not really oils that our bodies have evolved with, during human evolution. So in the Renew program, we tend to avoid those, and it is much better to utilize something like olive oil, avocado oil. They're rich in omega-3 polyunsaturated fatty acids, as well as even saturated oils, coconut oil, butter, animal fats, and so on. With regard to protein, the Renew program is really geared towards a plant-focused ketogenic diet, avoiding animal, meats, essentially. And one reason for that is that a high meat intake also is very acidifying for the body. It actually leads to further acidification of the urine, and it leads to high uric acid production in the body. And both of these factors also greatly increase the crystal formation that I mentioned and kind of the kidney stone formation. So by moving away from animal-based proteins, if you will, to plant-based sources, that's kind of the approach you're taking.
Got it. For a person with PKD, what are the risks of ingesting BHB supplements?
Yeah, so the risks are really not the BHB itself. BHB, is a normal molecule that our liver produces actually in much, much larger quantities than one could ingest from a supplement. And BHB is really not toxic to any. I mean, it's nearly impossible to poison a rat, let's say, with BHB, right? So you would have to take unbelievable amounts of it. What is a little bit more of a problem for people with PKD or renal impairment are the electrolytes that come with it, because BHB is what's called an organic acid, so it has to be neutralized with and then forms these salts. The strategy here is to use salts that are kind of beneficial and spread them out. So we're using a mixture of potassium, calcium, and magnesium. However, people that are nearer end-stage kidney disease may not be able to handle those electrolytes. So that's a caveat, and that's actually why this product, Ketosis I mentioned, is to be taken under medical supervision to make sure that it's appropriate for the stage of the disease.
Great. Can you join the Renew program if you live outside of the US?
That is a good question. We're working on this, I would say stay tuned and definitely sign up for the mailing list. It's a Renew program. I think initially the rollout will be in the US, and hopefully this will happen later this fall. But there's no exact date yet, but we're also working on Canada, for example, of course. Yes. So
we do have an inquiry specifically about Europe as well. So is that a stay tuned for the Renew program in Europe as well?
It is a little bit of a stay tuned. We're also working with nephrologists in Europe as well. That will probably take a little bit of time until that can happen over there.
Understood. What are the concerns with stage 4 in Renew? Also, is Renew recommended for transplant patients?
So the Renew program is really currently intended for mild to moderate stages of PKD, down to CKD stage 3. If somebody's stage 4, there would have to be probably more closely monitored and would probably benefit more from a really one-to-one, working one-on-one with a dietitian more intensively. So the Renew program is really like a class setting, if you will, right? So which is actually a nice feature because the participants meet once a week and can exchange their experiences, which I think really helps everybody to kind of stay on track and learn from each other. So if somebody is at stage 4, it may be better to actually work directly with a dietitian. For stage 5, that there becomes very difficult because everything really changes completely with regard to the nutritional requirements. So I think this particular program would not be appropriate for it. And again, a one-on-one interaction with a dietitian would be much better.
Okay, thank you. Next question. Is it safe to start a young child with ADPKD on some of these dietary suggestions, at least the intermittent fasting and keto diet?
So, that nobody has any data on this. This has not been, studied in an actual clinical trial, with children. And what I can say is that ketogenic diets have been used, and I think I mentioned this for about 100 years or so in children with epilepsy, and it's actually incredibly effective in epilepsy. It is, even. And the form of a ketogenic diet used in epilepsy is actually a really strict one. So it's much more strict than what we're using in the Renew program. And even those ketogenic diets are not detrimental to children with epilepsy. So from a safety point of view, clearly there has to be close medical supervision. But I don't think it's indicated at this point. So in a normal course of, an average course of PKD, problems arise later in life, in adulthood. Whether these dietary interventions are beneficial in ADPKD, that's a whole other question. It's also something that nobody has currently studied, that we are also, of course, are very interested in as well. So unfortunately, all I can say is stay tuned there. We're working on this as well. Yeah.
Understood. Thank you. Can you please explain why a keto diet, which is high in fat, does not increase cholesterol?
So getting into ketosis for the first time usually raises cholesterol levels. And that is actually completely expected and completely normal. The reason why it initially raises cholesterol is because our fat tissue, besides the actual fat, also contains a lot of cholesterol that just is stored in there, for a purpose. And as the fat tissue kind of lets go of the fat, it also lets go of the cholesterol. So you have sort of this initial increase in cholesterol, which actually tells you that it's working. Right? So that's how you're actually losing your fat tissue, and the cholesterol goes up. That's usually transient until sort of the body turns into a kind of a steady state level, and it depends a little bit on where one starts, and if somebody starts out very obese, it takes longer for the cholesterol to get back down, but it's a matter of weeks or months typically until normal cholesterol levels are achieved. And then it's these ketogenic diets can actually be beneficial and actually reduce total cholesterol.
So we have one that delves a little deeper, and this one experienced the rise that you speak of in cholesterol. The question states, I tried to cut statins, but when I began keto diet, my cholesterol rose too much, 400 milligrams total cholesterol. So I had to take atorvastatin again. What do you think about statins? Are they safe in PKD and PLD patients, or long-term keto diet could improve cholesterol, by itself?
Mm-hmm. Yeah. So again, I can't give medical advice, and always talk to a doctor. All I can say is, it is expected if one gets into ketosis, after maybe a lifetime of never have been in ketosis, cholesterol will go up. There's just no way around it. If you want to lose weight, you really have to have this initial increase there. It will improve over time, will probably go better than normal even after some time. Statins are very controversial, and there's a lot of scientists and doctors think that statins may not be really very beneficial, and that the cholesterol level is not as consequential as it used to be thought of. And a lot of the data on why people think cholesterol is detrimental is based on old sort of faulty data that turns out to actually not be correct anymore. So I think there's a lot of change right now in the medical community where people realize, hey, it's actually not necessarily a bad thing to have higher cholesterol levels, and statins might be more detrimental. So again, it's a question for a doctor. Of course, it takes a while for doctors to, kind of like learn the latest research results there. So it's also always a good idea to do some research on one's own and read up on it.
Absolutely. Okay, we have time for one last question. Are there any additional supplements recommended when on keto diet in the long run?
Well, again, no medical advice, but depending on what type of, there are many different types of keto diets. Now, I would count something like intermittent fasting as sort of a ketogenic type of diet, or a high-fat, low-carb ketogenic diet. There can be plant-based diets. There can be sort of carnivore diets. And each of those diets comes with their own possibility for nutrient deficiencies. For example, if you're a vegan, there's a much higher chance of being deficient in, let's say, iron. And those are things that should be screened, ideally working with a dietitian, get the blood panel drawn every once in a while, make sure one does not develop an iron deficiency, or if you're on a carnivore diet, you don't want to develop a magnesium deficiency or potassium deficiency and so on. So it really depends. It's probably a really good idea to always get monitored frequently, and depending on what the deficiency might be, or vitamin D, for example, is a common one. One would then supplement for this.
Okay, we do have a couple that sneaked through, so I assure you these will be the last two questions.
No problem.
Is lemon water good for PKD? Lemon tea good for PKD?
Lemon tea. Well, so there is, there's a little bit of literature on lemon juice for to sort of antagonize, kidney stones, if you will, with the rationale being, lemon juice is high in citric acid. Lemon tea, I don't actually really know what's in lemon tea. I'm assuming you squirt lemon juice into a tea. Maybe that's what the person means. The problem is the quantities of lemon juice one would have to take to actually have a measurable effect. It's huge. So one would have to drink lots and lots of, like a gallon, let's say, of lemonade to make a dent there. And then that comes with other problems. If it's like sweetened lemonade with sugar, you have all this sugar intake, which you don't want. Lemon juice tends to be very acidic. So if you drink it all day long, there is a tooth erosion. That's a problem that can happen. So oftentimes people don't actually recommend, drinking a lot of lemon juice for those reasons, and try to go for something else.
Okay, last one. Do you know of any research around PKD and anti-inflammatory agents like curcumin?
There's quite a bit of research that has been done mostly in animal models. So curcumin is one of these interesting molecules that has like 50 different molecular effects. So it does a lot of things. It is anti-inflammatory, and I don't think there's any human study really that shows any beneficial or detrimental effect. So I don't think currently anybody recommends curcumin. I know that a lot of people sort of on the internet say that they're using curcumin. I don't think there's any evidence one way or another currently to say whether it's beneficial or not.
Understood. Okay, Dr. Weimbs, that concludes our time for today. I can't thank you enough for a highly informative, very fascinating presentation. I'm sure a lot of questions will come in over the course of time as we replay the webinar and so forth. So I look forward to keeping in touch with you. And like all the attendees, I'm sure, look forward to seeing what comes out of your institute, and we'll be watching Renew with a close eye.
Super. Thank you very much, Jack.
Great. Thank you, Dr. Weimbs. So as we wrap up here on day one of the virtual PKD Summit, there's just a couple things in closing that I want to run by everyone. Day two is actually next Friday, September 10th. Again, starting at 9 o'clock with myself, and 9:30 is the first presentation. On the 10th, we will be joined by Dr. Adriana Carvalhal, who will be covering the topic Managing Anxiety and Depression with PKD. We will then move into the current landscape and the future horizon for children with ADPKD and ARBPKD, led by world-renowned researcher and nephrologist Dr. Lisa Gay Woodford. And then lastly, we will have the importance of diet and PKD with Roxanne Papineau. The last day, day 3 of the virtual summit, takes place on Friday, September 17th, where we will be joined by Dr. BJ Rilubit, and he will be discussing understanding kidney transplantation. We will then be joined by Joy Picard, Hamilton Chapter Coordinator, to speak about pre-implantation and genetic diagnosis and family planning with PKD. And then to close out the day, we will be joined by Alberta's Dr. Louis Gerard, who will be covering navigating the changing landscape of polycystic kidney disease. So if you haven't already, I do encourage you to register for day 2 and day 3 of our virtual summit. It's a month-long event taking place with a lot of excellent topics like we saw today. Of course, in closing, tomorrow is September 4th. So I do encourage you all to share posts, follow us on social media, Facebook, Twitter, Instagram, like, share our posts as well, and let's get as much dialogue out there in the public about PKD as possible. On behalf of myself, the Board of Directors for the PKD Foundation of Canada, I would like to thank Live Agency for all their behind-the-scenes support in making today as seamless as possible. I would like to thank those of you in attendance for joining us today and giving us your full attention, and look forward to seeing you at the next 2 events. Take care, and wishing you all the best. Bye-bye.